Hello, my friends. This is Dr. Siba Raychaudhuri from University of California, United States. I'm very thankful for this invitation to give this presentation in Rajasthan Cuticon Dermatology Conference. I'm especially thankful to Dr. Anil Budani for helping me to do this presentation in a virtual platform. Title of my talk is T-cell targeted therapies for skin diseases. I shall talk on T-cell targeted therapies as such on autoimmune diseases with a focus on skin diseases. I will discuss progress from biologic dimers to small molecules. These are members of my research group in this picture, and some of the research work I'll be presenting done by them, and I'm thankful to them. This is my disclosure. There is no conflict of interest in this presentation. What is autoimmunity? Autoimmunity is an immune response directed against an antigen within the body of the host. The definition does not distinguish whether the response is innate or acquired, and if acquired, whether it is induced by a foreign or by an existing in vivo antigen. These are heterogeneous group of inflammatory, generally chronic disorders of unknown cause. These diseases affect multiple tissues and organ systems. That's why these diseases are clinically challenging. Autoimmunity is induced by T lymphocyte activation and or B lymphocyte activation with autoantibody formation by the dysregulated immune system. Immune complexes together with the inflammatory cytokines cause the resulting tissue damage. Today, I shall discuss T-cell targeted therapies for autoimmune diseases with a focus on skin diseases. I shall discuss mechanisms of actions. So initially, first few slides, we'll have basic science discussion. I shall also discuss indications and adverse effects of some of the medicines which I will be discussing in this presentation. Pathogenesis of T-cell mediated inflammation in autoimmune diseases. So the primary immune response, the presentation of the antigen by the antigen presenting cell to the T-cell happens in either lymph nodes or in the spleen, the primary lymphoid organ. And there is generation of memory lymphocyte, memory T cells, and memory in respect to the antigen. So these memory T cells then has to migrate through the endothelial cell barrier, through the vessels to the organs, like in skin, in psoriasis, in gut, in inflammatory bowel disease, in joints, in autoimmune diseases of joints like scleroderma, psoriatic arthritis, rheumatoid arthritis, and in spine, in ankylosing spondylitis. So the migration from the vessels to the interstitium requires interaction of several molecules on the surface of the T cells and on the surface of the endothelial cells, such as CD11A on the surface of the T cells interacts with the ICAM on the surface of the endothelial cells, adhered there. Then, under the influence of chemotactic factors, such as chemokines, which are proteins, cytokines, okay? And then they migrate to the interstitium, and then they get exposed to the antigen. The antigen gets presented by the antigen presenting cells to the T cells, and here you can see there is interaction of many molecules, but the two signals, there are two important signals. The first signal is the T cell receptor, which is interacting with the MHC along with the antigen, and then for the perpetuation of the activation, we require the co-stimulatory molecules such as CD28 and CD86, and there is a full activation of the T cells, and that generates array of cytokines which will cause the tissue damage. Little more, autoimmune diseases requires genetic predisposition for this immune response inflammation. And along with that, it also needs environmental factors, such as, the genes HLA-B27, HLA-C, IL-23R, IL-12B make susceptible to spondyloarthritis, including psoriasis, psoriatic arthritis, HLA-DR for RA, HLA-DR-B1 for lupus, and so on. And this genetic predisposition under the influence of environmental factor like infection, toxin, biomechanical stress, and the best example is psoriasis. The streptococcal infection is inducing the gutted psoriasis as well. The mechanical stress of the Achilles tendon causing the enthesitis and plantar fasciitis. A good example of toxin are the drugs like lithium is inducing a very severe form of psoriasis. So it starts from a preclinical condition to a full-blown disease. In between, some people have a mild to moderate form of disease. So there is a spectrum. So can we identify or quantify this inflammation and determine the state of inflammation at different time points? So Dr. Siba P Raychaudhuri, member of our research group, came out with this idea that by applying PET imaging, positron emission tomography, we should be able to identify and quantify inflammation at different time points. So we induced arthritis in the mouse by foreign antigen, a collagen, a chicken collagen or a bovine collagen. And as you can see, with the time from day 0 to day 56, the paws and the fingers are getting swollen and inflamed, and it is correlating with the histopathology. In the day 0, you don't see infiltrate. With time, the pannus is forming, and as well, you see the PET signal is increasing with time, and it is maximum on day 56. As well, the mice got treated, and following treatment, in the lowest panel, you see the clinically paw swelling inflamed, pannus improved, as well, the PET signaling reduced. So this is the paradigm, at least in animal, that following antigen exposure, T cells are getting activated, and then there is adherence of these T cells migrating to the tissue and getting activated, liberating cytokines and causing proliferation, inflammation, and tissue destruction. But is it happening in human? So, with dermatologists, I believe we are smart people and we are practical person also. So I used the Kebner response to study in psoriasis. So we induced injury in psoriatic patients by putting scotch tape, by rubbing the skin with scotch tape. And then we took serial biopsies. Maybe some patients will develop psoriasis, some will not. As you know, Kebner response is around 40% in patients. So here you see in this tissue, and then we stained the tissue for T cells by CD3 antibody. Here you see in the first week, there is some accumulation of the CD3 T cells. In the second week, more CD3 T cells, these brown dots, and they're migrating towards the papillary dermis. In the third week, you see a lot of CD3 positive T cells, and they're hitting the epidermis, and they have induced the proliferation of epidermis. In the fourth week, more inflammation, more psoriasis. So, if this is happening, if this is the principle that T cells are causing the disease, then we should be able to block with an anti-T cell, like an anti-T cell antibody. So we made a CD28 antibody through Fujisawa, and you can see here the CD28 interacts with the CD86 for activation of the T cell. So we used a very specific humanized mouse model called SCID mouse model, severe combined immune deficiency. So we transplanted a psoriasis plaque. We did a safe biopsy, have that plaque and transplanted on that SCID mouse, and then we treated with CD28, and you see with time in the figure B, the epidermis is almost normalized and the infiltrates are gone. So with this proof of principle and many other elegant experiments from various research groups, first, specific anti-T cell therapy, you got abatacept, which is the CTLA4 Ig. So if abatacept is CTLA4 Ig with the FC portion of IgG1, and you see abatacept blocks the interaction of the CD8 with CD8T. And with this antibody, the first study showed in anti-TNF resistant rheumatoid arthritis, there was 50% clinical improvement. So now abatacept is approved for psoriatic arthritis with excellent efficacy on psoriasis. It is approved for rheumatoid arthritis, juvenile idiopathic arthritis, and trials are going for psoriasis, lupus, and graft versus host disease. Abatacept can be administered by either weekly subcutaneous injection or by monthly IV infusion following loading doses. So I was talking about the T cells and cytokines, and all of you know that there is various subpopulations of T cells, Th1, Th2, like Th2 is more important for atopic dermatitis. Th17, because it makes mostly IL-17, its signature cytokine IL-17, and IL-23, that's the growth factor for T cells, acts on the Th17 to make IL-17. So many drugs, many anti-T cells drugs has been made by targeting the IL-23 and IL-17 and its signaling proteins also, including the transcription factor ROR gamma T. We're talking about, early 2000, 2004, 5, we are doing this work, collecting the T cells from psoriasis plaque, collecting the T cells from the synovial fluid of psoriatic arthritis. And here you can see in the panel, the FACS plot on the left side and the figure C, that we demonstrated that CD4 T cells, activated memory CD4 T cells makes lots of IL-17. Similarly, on the right side, you can see by immunoperoxidase staining for IL-17, specifically with IL-17 antibody, both in synovial tissue, figure A on the right side, and B and C in the synovial plaques, we demonstrated IL-17 positive secreting T cells. And with time, we and others have dissected the regulatory role of IL-23, IL-17 cytokine axis in psoriasis, psoriatic arthritis, other forms of spondyloarthritis, and other diseases. Here you can see on the top the two cytokines, IL-12, IL-23, though IL-12 is important for Th1, but they are heteropeptides and they share one common component, P40. So IL-12 is important for making a gamma interferon. Not that much important, but we know that gamma interferon has a regulatory role in psoriasis, psoriatic arthritis. In addition, we know the regulatory role of Th17s, and which we have dissected. So IL-23 acts, it's again a heterodimer P19 and P14 on Th17s to make IL-17A, IL-17F, and the dimer IL-17A and F. Then we further demonstrated that it acts on the receptor on specific key cells important for pathogenesis of psoriatic disease, such as in keratinocytes. It is inducing epidermotropism of T cells, inducing neutrophil infiltration, Monroe's microabscess, and then also it is helping in the formation of penis by acting on the synovial fibrils and endothelial cells, inducing the angiogenesis, important for both psoriasis and the pannus formation. In addition, it activates the rank ligand, which activates osteoclasts and cause bone erosion. So this IL-23, IL-17 cytokine axis induces all the hallmarks, pathologic events in psoriasis, psoriatic arthritis, and certain other diseases. So obviously, this part is well known to all of us. We are using this anti-IL-17 antibody based on this principle successfully for last 17 years, for last more than 10 years, and these are brodalumab IL-17 receptor antibody, and other two are IL-17A antibody. We have a good experience on this, so I'm not going to discuss these antibodies. I shall discuss a little bit more on IL-23. These are relatively new antibodies, and still, they are getting evaluated in several other conditions. You can see here, right? IL-23 acts on gamma delta T cells, Th17, NKT, IL-C3, and important for several of these autoimmune conditions because they make IL-17, IL-22, TNF-alpha, GM-CSF. So, should it work? And already you know that I like to do some proof of concept experiments. So here, IL-23 MC mini circles. So these are the IL-23 genes. We injected and upregulated in a mouse model, and you can see extensive psoriasis in this ear of the mouse. And then when we treated these mice with IL-23 antibody, there was significant improvement of psoriasis. So based on these experiments and several other experiments, IL-7, IL-23, IL-20 are targeted treatments. Some of them are already in the market and some are coming. And not only for psoriasis, psoriatic arthritis, it is getting also tried for other conditions, including hidradenitis suppurativa. So one of these is guselkumab, IL-23 P19 antibody specific for IL-23, and it is already approved for psoriasis and psoriatic arthritis. And here in the bar diagram, you can see on week 24, a good response on PASI 75, more than 85% response. And similarly, a good response, ACR 20, that response on the joint, 60%. We are working on this. Trilrakizumab, already it is approved for psoriasis, but now we are evaluating, doing a phase 3 trial in psoriatic arthritis, and you can see a very good response, excellent response on ACR 20, 80% response. So these are some of the drugs which inhibits IL-23 and related cytokines, which are ustekinumab, guselkumab, trilrakizumab, and risanikizumab. Among that, ustekinumab, it blocks, you can see here, both IL-12 and IL-23. It's a P40 antibody, and whereas rest 3 are P19 antibody. So there is some advancement or advantage with IL-23 monoclonal antibodies compared with IL-17 monoclonal antibody. Anti-IL-23 MABs can be used in patients with inflammatory bowel disease. Risk for candidiasis is less. Efficacy in psoriasis is better. Longer duration of therapeutic effect. So they need less frequent administration, bi-monthly or tri-monthly. Similar to other biologics, with anti-IL-23, we expect immunosuppression, and overall safety and efficacy is good, but similar cautions needs to be taken, which we take with the patients with TNF-alpha inhibitors. Now this slide will be a little more interesting. Can we block two cytokines, like you see IL-17 and TNF? And why do we need that? As we mentioned that still our ACR20 response affecting joints is 60%. In 60% of patients, can we make it 80%? Our PASI 75 in general so far is around 90. Can we make it 95? Why not 100% PASI response? Can we do this by blocking two cytokines? So far we have two antibodies. One is ABT 122 has gone through some trial and showing good efficacy on both skin and joints in psoriatic arthritis. Another is bimekizumab. So bi means to mekizumab. It is an antibody against both IL-17A and IL-17F, and it is already approved for psoriatic arthritis in Europe. And significant efficacy has been seen both skin and psoriasis. In some of the trials, the PASI 75 response is repeatedly more than 90%. However, we are using anti-cytokine therapy for almost 20 years. And one thing definitely we are seeing, as I was mentioning, efficacy in 50 to 60%. And biologics generally need to be changed on an average in 3 to 4 years. So this suggests that the other mechanistic pathways are there, and maybe we need a broader approach. So as we are seeing with time, there is a primary or secondary failure. So can we block the inflammatory proliferation cascades more upstream or more downstream? Now this is an interesting slide. This is our work. Here you can see we are talking about Th17 cells, but this is not Th17 cells. This is CD4 effector memory T cells, CD4 effective memory cells. And what we found that CD4 effective memory T cells in psoriatic arthritis are making more IL-17. So it is skewed towards IL-17. That's true. And probably that's why the anti-IL-17 antibodies work for psoriatic arthritis and do not work for rheumatoid arthritis, where we are seeing a little more Th1 pattern. You see more gamma interferon, and we're seeing more TNF-20, TNF alpha. But here you see, though it is making IL-17, it is making IL-22, TNF alpha, gamma interferon also. So maybe that's the reason that at some point, we don't know the exact dynamics and kinetics of the cells. Maybe at some point it is making more of IL-17. So we are getting a good response with anti-IL-17. And then at some point we are not getting, maybe at that time it is making more gamma interferon. So then can we block multiple cytokines? And that brings us to the JAK-STAT inhibitor. And you can see these are the important cytokines, IL-2, am I right? That's the growth factor for T cells, any T cells, TH1, TH2, TH17. IL-4 should have been in this also, because that's important for atopic dermatitis. And you see IL-12, IL-23, TH1, TH2. All these things requires activation of JAK1. So if you block, let us say example JAK2, then you'll be able to block gamma interferon TH1 response, you'll be able to block IL-12 TH1 response, and you'll be able to block IL-23 TH17 response. So this substantiates that JAK-STAT kinase cascades are expected to have a significant role in the pathogenesis of several diseases, psoriasis, psoriatic arthritis, rheumatoid arthritis, lupus. So a lot of work is going on this field. And this is a list of some of the signaling proteins, which are now currently used or in trial in for autoimmune diseases. So apremilast, we all know, it's a PD4 inhibitor, and there are multiple molecules for JAK inhibitors. And in next few slides, I'm going to talk on JAK inhibitors, but I want to touch a little bit on these two other inhibitors, TYK2 and ROR gamma T. As you may notice that ROR gamma T is the transcription factor for the IL-23, IL-17 cytokine axis. So ROR gamma T has been in trial for psoriasis, psoriatic arthritis, good response. TYK2 has shown a very excellent PASI 75 response and in phase 3 trial for psoriasis. There are currently several JAK inhibitors you can see in the figure, and compounds 1, 5, 6, 9, that is tofacitinib, ruxolitinib, baricitinib, and upadacitinib are already approved by FDA and other countries for use of autoimmune diseases. And there are some other also which are not in this picture. And the other inhibitors are in various stages of clinical development across several inflammatory indications. and see the huge list of the JAK inhibitors. That itself says that how hot is this field. And here you can see that we are classifying this into two groups, first generation and next generation. So next generation JAK inhibitors, which is also showed in the figure, which are inhibiting particularly one JAK, JAK1, JAK2 or JAK3 or TYK2. Whereas the first generation JAK inhibitors inhibits multiple JAKs. In principle, these next generation JAK inhibitors might be used to treat selected inflammatory disorder and with lower dose and less adverse effects. So a snapshot, tofacitinib approved in 2012, baricitinib in 2018, upadacitinib in 2019, and these are oral medication and mostly for psoriatic disease and rheumatoid arthritis and inflammatory bowel disease trials are going on. But you see, ruxolitinib got approved just recently in 2021. And this is the first FDA-approved topical JAK inhibitor for treatment of atopic dermatitis. There's a huge potential for the JAK inhibitors of many autoimmune skin diseases, which includes atopic dermatitis, psoriasis, alopecia areata, lupus erythematosus, vitiligo, and graft-versus-host diseases. Tofacitinib so far, the trials has just proof of concept has showed significant improvement or efficacy in atopic dermatitis, and the trials are going on. But the most, I think, interesting among all this is its efficacy on atopic dermatitis. I'm pretty sure this is a very hot topic, and in the atopic dermatitis session, this will be discussed in details. I do not have much time, but you can see already 4 JAK inhibitors are approved for atopic dermatitis in different countries. 2 are topical, delgocitinib as an ointment and ruxolitinib as a cream, and 2 other are oral preparation, abrocitinib and baricitinib. These are already approved for atopic dermatitis. So key points are small organic molecules targeted against the signaling proteins such as apremilast, JAK-STAT inhibitors, or other kinase inhibitors, tyrosine kinase inhibitors, which are anti-fibrotic. They're very effective drug, looks like, for interstitial lung disease, another autoimmune disease, bring a new era beyond the anti-cytokine monoclonal antibodies for the treatment of autoimmune and inflammatory diseases. JAK inhibitors are effective treatments for atopic dermatitis, psoriatic arthritis, rheumatoid arthritis, ulcerative colitis, and as I mentioned, trials are going on for lupus, alopecia areata, dermatomyositis, vitiligo, and some rare autoinflammatory diseases with a type 1 interferon signature. Discussion of safety and adverse effect of JAK inhibitors in detail is out of scope. Overall, the safety profile of JAK inhibitors is reasonably good and does not vary among the different inhibitors. And these are causing immunosuppression. So we would expect increased risks of infection similar to other DMARDs. And there are some initial reports and further works needed to see what is happening, that is in respect to venous thrombosis and pulmonary embolism. There are numerically higher rates of deep vein thrombosis and pulmonary embolisms in some studies in JAK inhibitor treated patients compared to the placebo. Second generation JAK kinase inhibitors are more selective than currently approved drugs and are being studied with expectations to have better therapeutic efficacy and better side effect profile. Thank you very much for listening to me, and I won't be able to answer your questions. So many thanks, and if there is any way, you can email me if you have questions.